Okay, thank you very much, Gidon. Good evening, everybody. Thank you very much for joining us. It's wonderful to see some returning faces and also, of course, some new faces and names as well, which is brilliant. I hope that you really enjoy tonight's talk and that it is a dive into something that's kind of new to you. It's certainly something that I'm really excited to find all about. But just to give the general introduction, my name is Josh Foreman. I'm the head of science education and outreach here at Genetics. I'm delighted to welcome you to the latest talk in our Diving into the Genetic Pool series, the BRCA of the Gut, Lynch Syndrome Explained. So as Gidon mentioned, just to let you know that this is being recorded so that we can share the evening with others that weren't able to attend directly this evening. Genetics exists to raise awareness, educate, and test the community for Jewish genetic disorders. JGD, or Jewish genetic disorders, is a term that we often use to describe genetic conditions that are more common in people with Jewish ancestry, and that includes people from Ashkenazi, Sephardi, and Mizrahi backgrounds. Genetics tests for 47 of the most severe recessive JGDs, all of which have no known cure. Since 2014, we've screened over 7,000 individuals. We've educated tens of thousands of young people and identified numerous carrier couples who we've helped to go on to have healthy families. On top of that, we've also recently been appointed by NHS England as the official engagement partner for the Jewish BRCA screening program, working closely with High Cancer Care. Since launching the program officially at the end of January, over 25,000 people have signed up to be tested through this, which is the first of its kind groundbreaking program. BRCA gene faults are 6 times more common for those of Jewish ancestry compared to the general population, emphasizing the importance of the program for our community. Both our recessive screening program and the new NHS England Jewish BRCA testing program give people the knowledge and empower them to make the best decisions for theirs and their family's future health. For more information about either of these tests, please do visit genetics.org or email the genetics team. At this point, I'm going to pass over to my colleague Gidon Schwartz, our Outreach and Education Executive, who will be chairing the evening. Thank you and enjoy. Gidon?
Thank you, Josh. So as Josh mentioned, we often speak about BRCA within genetics as a genetic factor and a gene which increases your risk of various cancers. In the case of BRCA, for breast, prostate, pancreatic, and ovarian cancers. But in actual fact, there are many, many other genes which increase your risk factor for different cancers. And some are more prevalent in the Jewish community, like BRCA, some are more prevalent in other communities, and all work in slightly different ways. And so a group of these genes that contribute to cancers is known as a condition called Lynch syndrome, which increases your lifetime risk of colon, rectal, endometrial, gastric, and ovarian cancers. And so this evening, we have a couple of people I'll introduce in a second who have either started it or lived experience about it, who can really tell more about what it is and what it's like to live about it. And if you do have any questions, please feel free to put them in the chat or wait for the end. There will hopefully be time for some questions. So I'd now like to introduce Dr. Kelly Kahut. Kelly is the lead consultant genetic counselor at the Southwest Thames Centre for Genomics, St George's University Hospitals, NHS Foundation Trust, London. She holds an MSc from Sarah Lawrence College in New York and a BSc from Queen's University in Canada. Kelly has just completed a PhD, and by just, she passed this week, so congratulations to her, at the University of Southampton on genetic cancer risk management. With over 20 years of experience, she has worked at leading institutions worldwide, including Memorial Sloan Kettering Cancer Center and the Royal Marsden, and has received multiple awards, including a Doctoral College Directors Award, an NHS Confederation Innovate Award, and a Macmillan Professionals in Integration Excellence Award. Kelly also serves as the General Secretary of the European Hereditary Tumour Board and is involved in numerous professional societies and roles. So over to you, Kelly. Thank you very much for joining us.
Thank you so much for having me. I hope you can hear me okay. I've plugged in the microphone because it's going to be bedtime for my children soon, so I didn't want too much background noise. So hopefully that's coming through okay. And as I said, it's a pleasure to be here. I'm pleased to be asked, and I'm really keen as well to hear from the attendees if they do have questions so that I can tailor the content to really what you want to hear. But if you want me to share a screen, I can, or I can actually just talk and answer questions as well. I think it's not enabled as far as I can see here.
Oh, sorry, I will do that.
As you said, I've spent my career really um, specializing in cancer genetics, not just Lynch, but also BRCA and all of the other genes, and worked at a number of different hospitals seeing patients who've been diagnosed with the cancer and their relatives to try to determine if there is a high genetic risk for cancer by offering genetic testing where that's available. So, my PhD that you just mentioned is actually focused on Lynch syndrome. And what I've done is co-designed this website all about Lynch syndrome for patients and their families. And so it lays out kind of what is Lynch syndrome and the sorts of difficult decisions that people are then faced with when they learn that they have it. Um, you mentioned some of the main cancers. So there are some that are shared with the BRCA genes that you may know more about. But Lynch syndrome, the most common cancer that we see in families is actually colorectal cancer or bowel cancer. And the second most common is endometrial or womb cancer, uterine. And then we do, for some of the families, see an increased risk of ovarian cancer, but it does tend to be a different type of ovarian cancer compared to the type that people with a BRCA gene variant would tend to be at risk for. Nevertheless, we do discuss similarly the decision about maybe removing the ovaries and fallopian tubes for some people with Lynch syndrome after they've finished their family, if they choose to have one. And then there's some less common cancers, including more gastrointestinal types like stomach, small bowel, pancreas, and cancers of the urinary tract and the renal pelvis of the kidney. Um, there's some skin tumors, skin cancers that can be seen in certain families as well. So, in common with BRCA, this is a dominant condition. So, you only need to inherit a genetic variant or fault or mutation from one side of the family. So, normally it's either come from your mother's side or your father's side. It's quite rare for it to be a spontaneous or a new event. Um, so there are families, though, where they've inherited one variant from mother and one from father, and that can cause something called constitutional mismatch repair deficiency, which can affect children, but that is much more rare. Usually it's dominant and it's something that comes into play in adulthood. So just to think through what does it mean to have Lynch and the chances of cancer, there's a section that we've developed in collaboration with colleagues who've developed a database to sort of plot out and give the risks of cancer dependent on the characteristics of the person who's looking at this. So it's really about trying to personalize the risk communication as much as we can. So it's not just a one size fits all. There's not just one Lynch syndrome, but it actually depends which gene. So we have 4 genes that are mismatch repair genes that are involved in correcting errors that occur in DNA replication in the body. And when they're not functioning, these errors build up and it's called mismatch repair. So when we see a colon tumor, we can see if it's got an MLH1 or any of the genes that are related to Lynch syndrome. The other ones would be MSH2, and you don't have to remember all this because it won't mean a lot to you, but you can see how it's kind of similar to BRCA1, BRCA2, MSH6, PMS2. So there's actually 4 different genes, and some people might not know if they were tested many years ago which one, but you can see that it's quite important to know which gene. So in my PhD study where I was interviewing, some people were tested 10 or 20 years ago, and they said, well, I just thought there was one Lynch syndrome, but the scientific knowledge has moved on quite a lot in recent years where there's actually been an understanding of the real differences between the cancer risks depending which variant the gene is in. Which gene the variant is in. So you can see in MLH1, for example, compared to MSH2, MSH6, there's quite different risks here. So if people don't know, then we recommend going back to the genetics service and getting that up-to-date knowledge. And a website like this is something that people can access to kind of get them up to speed with what's current and maybe get back linked into services if they need to. And it's also a nice way for them to show information to their relatives. It's easier than trying to explain it themselves. So this was all developed with real people who've actually shared their stories in live videos like this. And there's some on BRCA as well on here because this website can be adapted later for BRCA genes, other genes, even other genetic conditions that might not have to do with cancer specifically. There's a lot that would be transferable. So the two big decisions for people with Lynch are about deciding whether they should take daily aspirin for at least 2 years to lower their chances of developing cancer. So we've worked with Professor Sir John Byrne in Newcastle, who's done all the aspirin trials in Lynch syndrome families and looking at, we know that it's effective, even for the general population who don't have Lynch syndrome, especially if they have a family history of colorectal cancer, bowel cancer, they might benefit from thinking about taking daily aspirin. But it depends on the person. So if they're over 70, they're more likely to have side effects. So we don't usually recommend that they take the daily aspirin. But anyone from 18 to 70, if they're in good health, they may well want to consider it. So there's lots of information here about how much can aspirin lower the chance of developing cancer? So you can see here comparing people who took it for at least 2 years every day to people who did not. In terms of people with Lynch syndrome that were in this study, it basically halved the risk. So it cut it by 50%, which is significant. But they're still working out kind of what is the best dose and how do people get the aspirin prescribed and what type of aspirin is okay to take. There's studies that are still going on at the moment to look at the best dose. So the trial was 600 milligrams a day, which some people feel is quite a high dose of aspirin, but now they're looking at as low as 150. Some people are even taking 75 milligrams as a practical measure because it's a baby aspirin. So there's lots as well about just really simple illustrations and explanations about the symptoms that people should be looking out for. Of course, with bowel cancer, it could be things like noticing blood in the stool or on the tissue when they go to the toilet, constipation, a change in bowel habit that's not normal for them, that doesn't go away. That can overlap with some of the symptoms of gynecological cancer as well, unexplained weight loss. So just looking out for that and going to the GP is a first step if they find anything. And there's some stories. So this website is more than just information. It's actually a decision aid as well. And that's about trying to work out kind of what are the values or what matters to the person at that time. So it can really be personalized and then people can put some notes down that they want to really prioritize that precious time that they get in clinic or on the phone with their doctor, genetic counselor to ask about things that really matter to them at the time. So it can kind of calculate what does it seem like this person's thinking? Do they want to take aspirin or not? Or are they undecided? And is there more to discuss? And there's lots of sources of support and information, but people often don't get shown these when they have their genetic testing and their diagnosis. So charities and patient groups and things can be really, really helpful to people, but we think we could do better in making sure that they find them right in the beginning. So perhaps we could speak about adding genetics to this at some point if you're happy. And then there's the choice to have a hysterectomy and possibly remove the ovaries and fallopian tubes. This doesn't prevent people from having children. It's generally something that's recommended after the age of 40, 45. So similar to the BRCA gene variants, it means that people can perhaps have children first and then think about having this risk-reducing surgery, which is obviously quite a big decision. It might bring on the menopause if they're premenopausal, but it would be recommended to take hormone replacement therapy afterwards so that they can protect bone density, cardiovascular health, and treat the menopausal symptoms. So again, this goes through kind of lots of information and linking out to the NHS charities and patient groups and going through a decision aid about this. People often have a lot of questions about hormone replacement therapy as well. So there's quite a lot in here regarding the different ways of taking HRT, the patches, the gel, tablets, and thinking about how they might have that hormone replaced. And generally, it's a lower dose than the body would have been producing naturally if the ovaries were still in place. So similar to BRCA, it's not thought to increase the risk of breast cancer, other cancers if someone would have been premenopausal anyway. It's just simply replacing a certain amount of what they would have been expected to have in their body. So it is recommended. But there's still a lot of, pushback sometimes. GPs aren't really feeling confident to prescribe it. So it's something that people do tend to have a lot of questions about. So again, people can think about what matters to them and questions to ask, and then get to kind of a summary of where it feels like they are at, and a checklist when they're going for something like discussing risk reducing surgery. That's a very hard decision. The timing has to be right, and there's a lot to consider with menopause and side effects. And so people might want to have this checklist to come in prepared with the questions that they really want to focus on during their appointment. So yeah, that's just sort of a whistle-stop tour, but this is freely available on the web if anyone has Lynch syndrome or wants to look at it, or has ideas about adapting it for BRCA perhaps as well. It'd be lovely to hear more from you. It's not only about those big decisions, but also things like diet and lifestyle advice, because that can play a role in cancer history. How do we talk to children? There's an expert here, Professor Alison Metcalf, with a video. Um, and some other areas where we talk more about the screening and just linking out to all the sources of support. So yeah, I'd love to hear maybe what questions there are. And I know you have another speaker who will be very informative for me as well to hear the experience that she's had.
So the one thing actually the other speaker asked is, can you talk about what the genes actually mean?
What they mean?
Do. Yeah, and what the genes actually do to cause the increased cancer risk.
Yeah, so the genes that I mentioned, and they're all called mismatch repair genes, or sometimes you hear it referred to as MMR. So they should be working in the body to go and fix the errors that occur normally, and it's expected that we, as the cells grow and divide and the body replicates the DNA, there's errors that occur, and that's a natural process. And these genes are involved in going and correcting them. So it's just a constant flow of errors being created, and then these genes, actually the proteins that are made by the genes, going and fixing them. So if there is what we call a pathogenic, or it's known as a disease causing variant in a mismatch repair gene, for Lynch and in other adult onset predispositions, usually it doesn't cause a disease, but it causes someone to have these increased risks. So essentially, someone with Lynch is born with one copy of the gene, has a variant. So it has what we used to call a mutation in the gene. So it means that the gene, it might make a shorter protein. It's not making the protein properly. So that protein isn't really functional in the body. So it's not doing the job that it was made to do, which is going and fixing these errors. So what can happen is there's short sequences of DNA that are prone to buildup of errors. So when the mismatch repair gene isn't making the protein to fix them, they build up. So when someone has a tumor, currently anyone with a colorectal or bowel tumor, or endometrial womb cancer, everyone should be screened for Lynch. So there's actually some simple pathology tests that can be done. And there was a big NHS transformation project over the last few years to try and make sure that that was done systematically in every hospital, that everyone who has Lynch should be picked up when they have a tumor. Even better would be the preventative medicine, where we find people before they have cancer. But if people present with cancer, they should be screened. And if they're told they have a mismatch repair deficient tumor, it's a sign that maybe it's Lynch syndrome, but not always. So there's a percentage of people with colorectal cancers and endometrial cancers who have mismatch repair deficient tumors, and that might help to guide their treatment. And then they may or may not have Lynch syndrome, which means that it's also relevant for the family because it's something that could be passed on. It may have been inherited, so other family members will carry it as well. Yeah.
And we've had one other question, then we'll move on to the other speaker and then come back to the question at the end, which is, are there any particular groups or ethnicities that have a higher prevalence of Lynch, like how there is the higher BRCA prevalence within the Jewish population?
Yeah, and then I've just seen Helen, so I'll come back to her question afterwards just to make sure I address that. But I actually, when I worked at Memorial Sloan Kettering in New York City, I worked with Ken Offit, who's the chief of genetics there. And back in those days, he was involved in describing some of the variants that are more common in the Jewish population. And so there are some what we call founder variants. But I haven't since that time, maybe 20 years ago, I haven't seen that we just screen for those because actually it's very easy to screen the whole genes. So, and we're even doing that with the BRCA, with the Jewish BRCA program, right? We're screening the whole BRCA gene, BRCA1 and BRCA2 genes, and sequencing the DNA throughout the whole gene, even though we know that there's more common founder variants. I think the technology has moved on so much now that we don't need to just test for a couple of variants. We might as well screen the whole DNA sequence of the gene just to check if there's any other variants as well. But yeah, there can be. It's not so much as with the BRCA genes where we do tend to see higher rates in certain populations in the world, but there are some founder variants. I mentioned the four genes, and I'm not sure if it showed the EpCAM, so it's a good question from Helen. The four genes are MLH1, MSH2, MSH6, PMS2. And with the MSH2 gene, you can actually have a deletion of part of something called EpCAM, which silences the MSH2 gene. So essentially, in terms of the recommendations that we give people in the cancer risks, those families with this silencing of the promoter region that turns on the MSH2 gene, essentially it's like having an MSH2 gene variant. So there's actually 5 genes, but one of them affects one of the 4.
Thank you very much for that most fascinating explanation. And we'll definitely come back to some of the other questions after our next speaker. But I'd like to now introduce Helen Bufton, who is a founder and trustee of Lynch Syndrome UK. So Lynch Syndrome UK was founded in 2014 after a group of patients met on Facebook, on a Facebook support page, and realized that there was just a lack of information and the screening was erratic. And so after much fundraising, a year later, they managed to scrape together enough money to register for charity status, as they put it. And all of the trustees are patients themselves, so they understand the need to spread awareness among patients and medical professionals and the general population, which they managed to do with the help of numerous experts. Helen herself had a brother who had 3 separate bowel cancers before he was diagnosed with Lynch syndrome and unfortunately lost his battle in 2016, 2 days short of his 46th birthday. She was diagnosed with Lynch syndrome in March 2013 and has a colonoscopy every 3 years due to her brother's early age diagnosis. And she has, after her first Lynch syndrome diagnosis, she was diagnosed with bowel cancer just 2 years and 10 months after a clear scope. And then her mother was diagnosed, and they actually underwent chemotherapy at the same time at the same hospital. There's much more to her story, but I will let her tell it herself because I'm sure it'll be much better than I can manage.
Hello, everybody. Thank you for inviting me, and thank you, Kelly, for explaining what Lynch syndrome is in terms that most people can understand. That was really good. So, as Gideon said, my story has just been told, and I'm a founder and trustee of Lynch Syndrome UK. We've got about 4,000 members now, I think, on our Facebook page. It's a closed page, so you have to ask to become a member. So anything that you post in there won't be seen by any of your family or your friends. We're all really dedicated to raising more awareness about Lynch syndrome and potentially saving lives, and people that have got Lynch perhaps having their cancers caught at an early stage rather than stage 3 or stage 4. I don't really know what else to say. Has anybody got any questions?
I mean, just tell more about your story. What happened with you? I mean, what you were saying to me this morning on the phone. Like, I mean, on how has it affected your life actively living with Lynch syndrome?
Well, I've had quite a few operations, but when I was diagnosed with Lynch syndrome, I actually stated to my genetic counsellor that I felt quite lucky because I would then be screened for any potential cancers, which people without a Lynch syndrome diagnosis won't have. So for me, I think it's a blessing. I just wish we'd have found out earlier about Lynch syndrome. My brother, I always say that he's my saviour, because if he hadn't have had those 3 bowel cancers, then we probably wouldn't have known about Lynch syndrome until myself and my mother were diagnosed, maybe at a later stage than we actually were. So we're doing loads of work with lots of Lynch syndrome experts, including Kelly. I think Kelly might have been to a couple of our conferences. I know that she's involved quite a lot with the work that one of our other trustees, Tracy, does. And the last few years, things seem to have gone boom, really, with Bowel Cancer UK and the Never Too Young campaign kicking in, which is absolutely fabulous. We're finding more and more families all the time with Lynch syndrome. Any other questions, Gideon? Has anybody got any questions at all? Just go into the chat. Oh, so what are the next steps for Lynch syndrome UK? Well, to be honest, we're just going to carry on as we are, raising awareness. We have lots of leaflets and booklets that we post out free of charge to anybody that requests them. We use the Royal Marsden Beginner's Guide to Lynch syndrome because that has got quite a lot of information in it, including aspirin, as Kelly touched upon earlier. There's also vaccine trials, I believe, that are up and coming, which is just going to be absolutely fantastic if they can prevent cancers or stop our genes doing what they shouldn't be doing. We have an annual conference every year for Lynch syndrome patients. This is going to be held at Warwick University on International Lynch Syndrome Day on the 22nd of March 2025. If anybody would like a ticket, you can order them from our website, but more details will be updated in the new year about that.
The other thing I'm intrigued to know about, you mentioned in your, I mentioned in your intro the fact that you underwent chemotherapy for your bowel cancer at the same time as your mother. I mean, what was that like as a family?
Well, my brother was also undergoing cancer treatment as well at the same time in a different hospital. I actually don't really know how my dad coped with all 3 of us being so poorly. It was horrendous, really. But, you know, there's lots of Lynch syndrome families with a massive cancer history and that have gone through more than we could ever dreamt of, really. I always think that if you told people about your cancer history and treatment, they wouldn't believe it because it just seems unbelievable that so many people in the same family can be affected by cancer at the same time.
So I mean, as a follow-up, what kind of support was there for you and your family? I mean, we work on the BRCA program, we work with high cancer care to support people going through the journey of diagnosis, treatments, preventative measures. What kind of support was there available for you at the time?
There wasn't any support at all. I joined the Lynch Syndrome Facebook page about 12 months after my diagnosis. Prior to that, there just wasn't any support. Nobody knew really what Lynch syndrome was. So even the medical professionals that I came across going through my treatment didn't have a clue about Lynch syndrome and what it meant. a lot of the time they'd say to me, well, you're far too young to have bowel cancer. I was 44, and that's not young for a bowel cancer with somebody with Lynch syndrome. And that's another reason why we wanted to set the charity up, so that we could support people. Yeah, we can't do a lot about the medical side, but we can be there and talk to people who are going through the things that we've been through.
And I can imagine just the shared experience is the most important and best thing that you can give.
Yeah, it's very important. Yeah, very important. And you can sort of you know what they're going through. You can sympathise. You can lend a listening ear, and you understand exactly the tribulations that comes with having Lynch syndrome and or a cancer diagnosis.
And so what is the screen? Is screening for Lynch syndrome only offered? I'm kind of might bring Kelly in, but this one, is it only offered after a cancer diagnosis, or in your case, if there's a particular family history, or like what would allow someone to have this screening for it? And I don't know who's best to answer between the two of you.
Well, from my experience, as I said, I was having colonoscopies every 3 years because of my brother being so young when he had his first 2 cancers. If he hadn't have had them cancers at such an early age, I probably wouldn't have been given any screening. So generally, if a relative is diagnosed with Lynch and you're diagnosed with Lynch, then you will have your 2 yearly colonoscopies. Depending on which NHS trust, you might be able to get gynecology screening, and that's about all that's offered, if I'm being totally honest. I'm sure Kelly will be able to add to that.
Yeah, I think that's right. I think we've already seen, fortunately, a lot of advances in picking up families earlier because, the stories that Helen and many of the people that come to the conference for Lynch Syndrome UK have, involve a lot of loss, that there were several generations of family that were affected by cancer, often at unusually young ages. So particularly with the bowel cancer, it's not what we tend to see in the population where people are over 50, 60, 70 years old. Unfortunately, the bowel cancer tends to occur also not only more often, but at an earlier age. So similar to the breast cancer in BRCA. So that's why if we identify that someone has Lynch syndrome, we recommend colonoscopy every 2 years, starting from age 25 to 35, depending which gene is involved. And so people would have to go through the preparation to empty the bowel. Some of them say that's the worst part. And then maybe some kind of medication that helps them get through the procedure and it kind of makes you forget about it, a lot of people say. But it's to really look inside the clean bowel wall all the way through to see if there's any polyps that are growing, any sign of cancer. And it's been determined over many years of studies that every 2 years is appropriate. But it's a lot to go through. It's a cycle of waiting for the next screening appointment and then going again. And to say about how do you get tested, well, yeah, it's normally that someone has had a Lynch-related cancer and they're the first person in the family to have genetic testing. Nowadays, as I said, there should be universal screening of every bowel tumor, every endometrial tumor for Lynch. And it does sometimes guide treatment, even if they have this hypermutable phenotype, we say, which is like lots of mutations are seen in the tumor. It can be that it's just in the cancer cells and they don't actually have Lynch. It's not something that's inherited, but it still might help the oncology team to select the best treatment. And we see that tumors that have this high mutability can respond very well to something like immunotherapy. So that's quite exciting because these targeted treatments can work very well, but don't have so much of the side effects from traditional chemotherapy. So that's one of the ways that treatment can be tailored. There's also the vaccines that Helen mentioned that are very exciting. There's a Swiss company, there's one in Oxford that are developing vaccines for people with Lynch to try and prevent them from developing cancer. And that's targeting, there's something called frameshift peptides that build up because of this mismatch repair deficiency. So it's these proteins that are in the body that immunotherapy can target, and vaccines can actually try and prevent a cancer from having a chance to develop by using the body's immune system, turning it on. So those are some of the exciting advances. And because of the universal screening, because of increased awareness, and also population screening studies, or where people are having the Lynch genes included in panels where they might have previously in the old days maybe been tested for one or two genes. Now there's a lot of big gene panels or even whole exome, whole genome sequencing that people are having, and they could be picked up by accident, really. They weren't coming in with a family history they even really recognized was suggesting Lynch, or maybe no one's even had cancer in their close family, but they could be found to have Lynch syndrome. And especially with the PMS2 gene, the chances of cancer are actually quite a bit lower than the genes that were discovered first, MLH1, MSH2, and then later MSH6. And EpCAM was found to be linked to MSH2. But actually with PMS2, the cancer risk can be quite low and similar to the general population. So it's not always clear, for example, if they should have their ovaries removed, it's not recommended, or even how much the risk is higher than the general population average risk if they don't have a family history. So that's coming into play now, where we're finding people by accident because they just happen to have a really broad genetic screen for some other reason, or even some insurance companies are just offering it for health checks. So we're picking up more and more families with Lynch. Biobank study and other studies worldwide. So we're getting an evolving understanding of the what we call the risk penetrance estimate. So the chances of developing cancer depending on the gene, but also we see differences in families. So we need to understand that more so we can give the right advice. Those 4 sets of guidelines from the UK Cancer Genetics Group, which are online, about the screening with colonoscopy, hysterectomy. Gynecological screening is not recommended on the NHS, but there are some research studies that have been done. And then the newer things like the vaccine and targeted treatment. Inflammatory bowel disease is not linked genetically. I mean, people might have it. It might increase their risk of colon cancer, but it's 2 separate things. Aspirin, how does it work? Well, it's an anti-inflammatory. They're still studying the exact mechanism of how it reduces cancer. It was originally found kind of by accident when people were taking aspirin in the cardiovascular risk trials, and they found they have a lower risk of cancer. And actually, you can Google and see some videos from my colleague, Professor John Byrne, who did the trials, and he did one where they took resistant starch. So he has this green banana effect, saying, oh, if you eat a green banana a day, that's not quite enough, but it's just the idea in people's minds that if you really increase the fiber in your diet, the resistant starch, that also lowers the risk of cancer. So there's different kind of lifestyle factors that people might consider as well. So you can't screen for Lynch on the NHS if you just don't have any family history at the moment. But my colleague, Professor Ranjit Manchanda at UCL and University College London and Queen Mary University of London, sorry, he's based at Charterhouse Square. He's just starting this study called Protect-C genetic screening. So you may know about that. And I think it's just for women, and the Lynch genes are probably on there, but I'm not too sure. And he's also doing a study. Yeah,
They are on it. It's almost the build up from the BRCA gene, which is interesting seeing how the BRCA study is now moved into the Protect-C, which does include the Lynch genes.
So that might be a way for more people in the population who don't have a family history to be screened and maybe be picked up preemptively to know about Lynch before it's actually affected people in the family, like what happened with Helen's family. So that would be what we want to see, is the preventative, the knowledge beforehand, recognizing that the more that we do that, the more we might be over screening people because maybe their risks are lower if it hasn't actually affected anyone in their family in the past.
How could that be? Surely, if you've got the genes, you've got the risk.
Yeah, it's just what is how much risk? So we think there is an increased risk even with PMS2, but in some of the families that have been picked up, like in the UK Biobank, their risk seems like very close to the average risk in the population. So everybody has risk for these cancers, whether they have Lynch or not, family history or not. We can't take away that background risk. And cancer, unfortunately, is just common in general in the population. They say up to 1 in 2 people will have some type of cancer, but it's how much is that genetic increased risk? And for some families, it's a lot lower than we thought in the past for some of the gene variants. And there could be modifier genes because you have about 20,000 genes. We're just talking about one variant in one gene. It may be that there are variants in other genes that are pushing up the risk in some families, and some variants in genes can be protective. They can lower the risk. So depending on the combination of variants that people have, and it can be different within families because you only share about 50% of your genes with your sibling, for example. Depending what mixture of variants the person has, it can affect where they are on that risk curve that we see. It can change the treatment options in terms of considering something like immunotherapy. It doesn't tend to mean that we have to remove the whole colon if someone has a bowel cancer because there's not a really high propensity for growing polyps like some other genes that we do test for that are called polyposis genes, where people can have hundreds of polyps and they do need their entire bowel removed to prevent cancer. But Lynch doesn't tend to have lots of polyps growing. And how come there hasn't been a wired? Yeah. So with any of these gene variants, that's a really interesting question is like, why does it increase the risk of certain cancers and not others? That's a really great question. And it just that it's, with any genes, you can do studies in the lab to show how much are they turned on in certain tissues versus others, or how important is the function of the proteins that gene makes in certain organs. So we do see cancer-specific risks. There are some genes that have an even wider spectrum of different cancers, like the TP53 gene, causing something called Lynch syndrome. They can have quite a number of different cancer risks, which makes it hard to devise screening. So they've actually looked at whole body MRI for those families and even in children as well.
I think for one final question, I'm going to hand over to Josh, who has just sent it to me privately to ask it to the two of you. Please.
Hi, firstly, thank you so much. That's a real insight into a genetic basis of cancer that I just simply don't know that much about. I'm kind of getting the vibe that that's the general the general response for it, and it's one that's becoming more and more well known, as Helen mentioned with the Bowel Cancer UK kind of picked up on Lynch as well. That idea of greater awareness and greater understanding is only going to help save people fundamentally. And firstly, thank you for the work that you're doing on it. I think it's brilliant. It is worth noting, actually, we work really closely with Ranchada as well. I know you mentioned him and his Protect-C study. He is really looking at how can we take the lessons from the Jewish BRCA screening program and apply those on a national level. And he is including the Lynch genes in that. He's currently screening, we're in the process of screening 2,000 women for a range, I think it's 6 cancer-related genes, of which Lynch are a few of them, but mapping it to a demographic of the entire UK population, well, English population, I should say, because I think it's backed by, or it's for NHS England rather than kind of as the whole country. But just, I thought a nice question might be, because one of the feelings that I'm getting is that this is something that we're at the kind of the beginning of the journey of making this a broad kind of more well-known public thing. If we just happened, and I wish we did, have an open line to Wes Streeting, the Minister in charge of the Health Service, what would be the dream outcome of a conversation with him? And that's both to Kelly and to Helen.
You able to go first, Helen? Because I'd love to hear from you what your priority would be.
I'm trying to think of an answer, Kelly.
Well, I would just say that Lynch, you're quite right. I think we're at the beginning of a journey, but it's been known for pretty much as long as BRCA. It's been, it's been decades that we've been able to test for Lynch. But as I said, it was only in families that really came with a suspicion of Lynch, whereas now we're rolling out more in the population to preemptively screen for it. And it's not rare. Where it was previously thought these genetic conditions were rare, Lynch is not a rare condition. It's one of the most common genetic predispositions to cancer. And so it's probably at least 1 out of 400. Some some studies say 1 out of 270 people, regardless of family history, have Lynch. And the National Transformation Project in the NHS was saying, when they started it a few years ago, 95% of people in the population who have Lynch didn't know about it. So they were trying to change that. There's a multi-pronged approach. There's screening all the tumors, but even better yet, going into the population and finding people before they're diagnosed with cancer. So there's lots to be done for preventative medicine.
That mirrors the journey that BRCA have gone on, or the journey that as a society we've gone on with BRCA almost identically. Ranjit assessed that around 90% of BRCA carriers would be unaware of it on the kind of the existing framework, which is screening after a diagnosis and then cascade, i.e. the rest of the family being screened. So it sounds like we can learn a lot from the BRCA and apply it to Lynch for a really positive outcome as well. And especially, as you say, preventative medicine is becoming the buzzword. Brilliant. Thank you so much. Helen?
Hello, yes. I mean, for me, in the ideal world, if everybody that wanted to be tested for any cancer genes could, then that would be brilliant. But I know ethically that's not achievable, and a lot of people don't want to know if they've got a genetic gene cancer risk. Some people kind of put their head in the sand a little bit, which is understandable because it is scary. But for me, if you know you've got one of these genes, you can take preventative steps. And also, if you're symptom aware and you go to your doctor, say you go to your doctor with changes in your bowel habit, for somebody that's not been diagnosed with Lynch, your doctor will probably say, oh, come back in 6 weeks if nothing's changed. And with somebody with diagnosed with Lynch, I know that I can go to my doctor and I can take the Royal Marsden booklet and say, well, these are my symptoms and I'd like to be referred. And then usually it works and I am referred. So and for me, that's one of the positives of being diagnosed with Lynch syndrome.
So great. I feel that's a great line to finish on. So thank you very much to Helen and to Kelly for that fascinating insight into a whole stream of medicine, which I remember from a half a lecture in university that was interesting but couldn't really remember. So really delve again, fascinating. And with our next scientific lecture will hopefully be in February in person, in conjunction with the Genetic Society to mark Women and Girls in Science Day. So keep your eyes peeled. We'll be sending things out as soon as we have the final details confirmed. And thank you everyone for coming and have a nice evening.